Hello, everybody from around the world. Thank you so much for joining today. My name is Lucy King. I'm with the international NGO Interburns. It's an honor to welcome you today to day 4 of World Burns Week. I'll just talk through some instructions about translation, if you'd like to translate some of this webinar. If you need translation, you can activate the auto-translated captions. The speaking language is obviously English, and then you can change the caption language to your language. I'll give you a few moments in case you want to do that. And also just a reminder that if you want to pose the panel any questions, please use the Q&A button at the bottom of your screens. Thank you. So this is day 4 of World Burns Week. World Burns Week is an initiative to advocate and bring together all those, whether individual, organizational, healthcare workers, survivors, or legislators, to shine a light on the importance of improving burn care and prevention, especially in low-resource settings. The theme of the day, preventing the chaos of mass casualty disasters, is especially relevant. We're delighted to have speakers with first-hand experience in witnessing, managing, and planning for such disasters. Burn mass casualty disasters can happen anywhere at any time. They often happen in under-resourced or fragile settings that are ill-equipped for the flood of victims. Today, we're going to hear from people who can really talk about what is the impact of a burn mass casualty disaster? What does the system, how does it come under strain, and what could be done to plan for such a situation? I'd like to introduce Dr. Tanvir Ahmed. He's a Bangladesh-trained plastic surgeon and associate professor of plastic surgery in the 500-bed public teaching hospital, the National Institute of Burn and Plastic Surgery in Dhaka, Bangladesh. He's involved in postgraduate teaching, supervising trainees, and he's designed several educational programs. Tanvir uses his 17 years of burn care experience to develop sustainable burn awareness programs, infection prevention, and acute care. He will just give you a short introduction to the subject today. Thank you.
Thank you, Lucy. Good morning from our side. This preventing the chaos of the mass casualty disasters. And this is more common in this part of the world, mostly in the developing world or in Asia and Africa. But some of the areas, it actually happens sporadically, but in this part of the world, it is a common scenario from starting from a small casualties to a bigger one. So this year's theme is the failure to plan can mean planning to fail. So actually, burn mass casualty disasters can happen anywhere, anytime, often in under-resourced or fragile settings that are ill-equipped for the flood of victims. You understand the number of the population compared to the healthcare facilities or the burn care facilities. Specifically in Bangladesh and India, very recently in this part of the world, they faced several mass casualty burn disasters, including some plane crash over the schools or the medical schools. And careful planning at the local, national, and regional levels, even up to the international level, can help to reduce this chaos, complication, and the fatalities. And leading experts actually are here and we'll discuss the priorities about these things. So, welcome everyone to this session. So, at the beginning, we have 5 speakers. At first, I would like to introduce Dr. Jayesh. And Dr. Jayesh is from India, is a professor and head of the Department of Burns and Plastic Surgery at the BJ Medical College and Civil Hospital, Ahmedabad, Gujarat. And he has over 23 years of experience and has been co-editor of the Indian Journal of Burns. That he published papers related to burns in national and international journals. And Dr. Jayesh will give a first-hand account of 2 mass burn casualty events that impacted his hospital. So just enjoy the Dr. Jayesh.
I am Dr. Jayesh P. Sachdev, working as a professor and head department of burns and plastic surgery at Civil Hospital, Ahmedabad, Gujarat. Today, I will share my experience during managing the mass casualty which we have experienced in last few years. Mass casualty incidents challenges the hospital preparedness, coordination, and clinical management. Our department of burns and plastic surgery faced two major mass casualty incidents. In this presentation, I am sharing our experience. In 2008, there were a bomb blast at trauma center of the civil hospital. It was one of the last bomb which exploded near trauma center. There were serial bomb blasts in the city. Total, there were 13 bomb blasts. At the interval of few minutes, at various places in the city, there were 12 bomb blasts, and it was planned in such a way that when the patients, their relatives, everyone there at the trauma center of the civil hospital, then the last bomb explode at the trauma center, which is the epicenter of the hospital. So it was a very scary moment. And second incident, which occurred recently in 2005, there is a plane crash near the BJ Medical College and Civil Hospital Hostel student area. The flight was going from Ahmedabad to London. It collapsed, blast on the residential area. So first, I will talk about the 2008 bomb blast. The location of bomb blast in the hospital, it was near the trauma center of the civil hospital, Ahmedabad. Date was 26 July 2008. From afternoon, there were a report of the various bomb blast, serial bomb blast in the city of Ahmedabad at the interval of few minutes. So the injured victim, which were having burns as well as other injuries, were coming to the hospital. So there was a huge rush at the trauma center with patient attendant, and other person. And the last bomb blast which occurred, which was near the trauma center, which was the main place where these patients were managed. It was damaged, and it has become dysfunctional. Total 34 burns patients were admitted in our ward, and can you, ma'am, previous slide? Total 31 one patient were admitted. Some were having some other injuries like rib fracture, chest, head injury, along with that. And 10 patients were having minor burns, which were treated conservatively. And during this management, we lost the 5 patients, which were having major burns and associated injury. The unique challenge of this incident was this explosion was at the civil hospital in the civil hospital campus near the trauma center. It disturbed the hospital disaster plan. It is a functional hospital. There are many patients were admitted in the hospital. It is a multidisciplinary hospital of 2,200 beds. Part of the serial bomb blast in the city, it was one of the part of the serial bomb blast in the city. So there was fear that is this the last bomb blast, or there can be some other blast also. Last it may be under the hospital premises also. So trauma center become non-functional. There are other inpatient in the hospital also. So there were fear among the treating doctors, nursing staff, other indoor patients, their relatives. So how we have managed that, in we wards where less patients were there, they were shifted to the another ward, and dedicated ward was opened up. So was where all these injured patients were taken up, irrespective of injury, either they be trauma or burns or some head injury, or they were all shifted to one ward. Now once the patient was stabilized, they were shifted to the respective wards. Like in our case, it was a burns ward. There was also fear among hospital staff and other indoor patients and the relative. See, the first time hospital was targeted with such a planning that after serial bomb blast in the city, when patients started coming to hospital, last explosion was near the trauma center. This is the board of the trauma center which was damaged. As trauma center is a beating heart of the hospital, and acute care and severely injured patients are taken to here. Not in a trauma, the other patients were also coming to this trauma center. Emergency trauma patient received first-hand resuscitation, stabilized, and then shifted to operation theater, ward, and intensive care unit as per their need. This epicenter of the hospital managing the victim of the disaster was targeted, so it becomes non-functional. These are the few photos of that site, actual photograph of the site where these incidents happen. These were the, you can see the magnitude of the blast, where the vehicles have been damaged, some roads and materials has been dropped down from the respective site. So, looking at this photograph, you can come to know that what was the magnitude of this blast. These are some internal photograph of the trauma ward. These are the first is area where the ward area, and other is where the one bed is there, some dressing room there. Now, after 17 years, in 2025, 12th June 25, we have also faced another mass casualty. The flight was just took off from the airport, which is approximately 7 kilometers from the college and hospital. Flight has started was from Ahmedabad to London. The passengers, crew, pilots, student, hospital employee, resident of the nearby society, bypass, etc. were victim. Only one passenger was survived. These tank were filled with fuel, but it was just take off. It after Tokyo, within few seconds, it dropped down on the mess and hostel building of BJ Medical College and Civil Hospital and residential area. Relatives were near the airport. They have come to see of the patient, so they immediately rushed to the hospital. We have mobilized our staff of bunch unit. Once we received the message from the authorities that there is expected huge amount of patient, we have mobilized the patient to the trauma center. 10 patients were admitted of the from this, and we lost the 4 patients having major burns. These are the few actual photograph where the hostel building, residential of the student are there. The part of the plane was gone to the mess, and where the some part of the plane will also dismantled, and the site of the injury. There, it is believed that more than 1 lakh liter of fuel was in your tank. So it from that it comes to the how much heat has been generated. All the crew member, passenger were expired. These are the few photograph of our hospital triage area. This is a photograph of triage area of our emergency ward. This is our burns ward dressing room. And this is our operation theater of for burns patients. This is our one photograph of a burns ward. Now, these are the few survivors of the 208 victim, and this is the only lone survivor of the plane crash victim, which was managed by our hospital. So, what is the take-home message? The both incidents reinforce the importance of preparedness and adaptability. Rapid triage, teamwork, and communication remains the cornerstone of the mass casualty management. Communication and chain of command are critical. Surge capacity must be built into hospital and burns care infrastructure. Psychological support essential for staff, patients, and their relatives. Single spokesperson recommended for media handling. A regular disaster preparedness drill is vital and advisable. Thank you.
Thank you so much, Dr. Jayesh, for that very graphic account of the impact of different types of burn disasters. I really felt you conveyed the fear among hospital staff and the impact that when you have a non-functioning trauma center, the impact that that can have on the operations of the hospital. And you underline the importance of rapid triage, teamwork, and communication, as well as regular disaster drills. I'd like to come on to our next speaker now, Nikki Alorto, who will talk about a system of triage that she has developed in South Africa. Nikki is a general surgeon with critical care training. She runs a burn service in Pietermaritzburg, South Africa. She's involved in all aspects of burn care, from research and teaching, resource management, surgery, outreach, and telemedicine. Nikki has developed multiple databases and apps for burns and has a passion for getting the basics right and being practical in the development of the service. Thank you, Nikki.
Good day, ladies and gentlemen. Welcome to World Burn Week. My name is Nikki Alorto, and I'm a South African burn surgeon, and I'm going to present to you triage as a novel concept for guiding burn care in low-resource settings. Triage has typically been described in mass casualty incidents, and mass casualty incidents are defined as a sudden surge in patients that overwhelm the capacity of the local medical resources and often result in preventable mortality and morbidity, typically around natural disasters, violence, or road traffic accidents. It leads to challenges in the clinical service delivery, particularly in those with resource-limited settings. What is triage itself? This is the sorting of and allocation of treatment according to a system of priorities designed to maximize the number of survivors. Or it can be considered as the assigning of priority order based on where funds and other resources can best be used, are mostly needed, and are most likely to achieve success, which I think is very important. And there's much literature describing the need for triage in mass casualty incidents. But what about thinking of triage in a different way and using it in a low resource setting, particularly because we have a high burden to resource ratio, and it's an ongoing challenge with insufficient beds, expertise, as well as insufficient equipment and consumables that are needed to treat burn injuries. Priority systems have been described by the Committee on Crisis Standards of Care as a systematic approach aimed to select patients to be prioritized for intervention, and again based on a more urgent need and greater potential benefit for the patient. Crisis standards of care are defined as a substantial change in the usual healthcare operations and the level of care that it is possible to deliver, and it is typically justified by specific circumstances and formally declared by a state government in recognition that a crisis has occurred and that operations will be in effect for a sustained period of time. But what about low resource settings? We experience not a change in care that was previously delivered, but rather experience that the crisis is ongoing with a high burden of injury and low resource access. We have recently published on this topic and attempted to provide a framework for management of care delivery in a resource-restricted service, specifically focusing on access to surgery for burn-injured patients, and our study aimed to describe the efficacy of this prioritization system, where the primary outcome was the ability to perform surgery in the priority group of patients within 3 days of the decision. What did we prioritize? And there were three. So one criteria for priority surgery was large surface area burns. This was specifically deep burns, more than 15% total body surface area, and we felt the need for early surgery was in the attainment of physiological source control. Our second priority was invasive burn wound infection as part of sepsis source control, and the third criteria was a full thickness or fourth degree component burn of the hand, foot, or limb, where there was high risk of limb loss or significant deformity or dysfunction if not operated on early. However, priority criteria may not only be linked to the need for surgery, but can also be linked to the need for ICU or the need for transfer to a burn unit or a burn service. In Pietermaritzburg, 94% of our referrals meet the standard national transfer criteria as you've seen here, and these transfer criteria come from high-income country settings. To manage that burden, we have implemented tools particularly the Vula Medical Referral app that allows us to communicate with our referral area, which is 3 million people, and using that application to facilitate appropriate transfer to the Pietermaritzburg Burn Service rather than a blanket transfer of everybody that meets standard criteria. For example, this is a hand burn. It would meet the criteria of a special area burn, but is actually quite minor. It's small in surface area, it's superficial partial that should heal, and in conjunction with specialist discussion can be successfully managed at a district level care or a clinic level care. And this is just an example of how we use the Vula app as a tool in order to provide appropriate triage of our patients. We must be cognizant that selecting the criteria for triage and priority will be dependent on local capacity, and that might include beds, it might include expertise such as the surgeon, nursing, the anaesthetist or the rehabilitation team, theatre time, access to ICU, and access to blood and certain equipment. And it is important to understand the local thresholds. Take, for example, a massive full-thickness burn injury in a small child. And part of triage for low-resource settings should include a robust palliative care policy, remembering that the thresholds for the institution of palliative care will be different in low-resource settings. And the threshold, what is defined as a massive surface area injury, or where age would determine survivability, and of course inhalation injury, we must be cognizant of survival, and that where survival is unlikely, we should be instituting palliative care. And we need to be realistic, and in deep burns, the donor site availability and ability to graft timeously should be a major consideration when determining palliative care policy. In conclusion, global standards of care for burn injuries are desirable, but not always possible. And we need to use the concept of triage in a novel way in order to provide or manage our limited resources, which may include access to surgical care. It may mean using triage for referral to a higher level of care, or for the institution of palliative care, remembering that local context is extremely important. Thank you.
Thanks, Nikki, for summarizing the systematic triage to manage overload of the patient in resource-limited setting, which is really very important for the developing world. As you know, the number of the patient is really very big compared to the facilities, and sometimes it disrupts the usual function, even the emergency care. And now I would like to uh, introduce Dr. Chong Sijak. CJ is from Singapore, and he will be speaking on the mass casualty response, his experience from Bangladesh. And he is a consultant plastic surgeon at Singapore General Hospital and Chief Medical Officer of the Singapore Prison Service. He is the Adjunct Associate Professor of Duke NUS Medical School. He was a past president of Asia Pacific Burn Association, and he is currently the president for the Association for Burn Injuries in Singapore. Dr. Chong is a colonel and alternate chief naval medical officer in the Republic of Singapore Navy, and he has planned and taken part in humanitarian and disaster relief missions since 2000, and notably in Banda Aceh, Semeru, and Nias Island, and in the Gulf. He also joined in the response in Bangladesh too. So welcome, Dr. CJ.
Thank you, Tanvir, for the kind introduction. I'm CJ. Welcome everyone that comes for the World Burns Week. I've actually had some experience in mines casualty, but of a slightly different nature, not of burns, but for earthquakes, tsunamis, back in the early 2000s. So today I'm sharing the lessons I learned from someone who's bringing extra resources to Bangladesh from the Milestone High School plane crash in July 2025. In July 2025, 21st of July, it happened in the afternoon where many students from this privately run school, unfortunately, a fighter jet went into the school. There were purportedly about 200 mass casualty at the situation. This was because it was during lunchtime. The school was having extra classes, so there were quite a lot of casualties. So it attracted a lot of media attention. And the number of casualties were more than 200 on when it was first spread. The National Institute of Burns and Plastic Surgery had a memorandum of understanding with Singapore General Hospital, and that was why how we were activated to chip in. I think no all burn center worldwide will face a problem when you have a large number of casualties. Out of this so-called 200 casualties, 55 significant ones were triaged and brought to the National Institute of Burns and Plastic Surgery about 45 minutes away from the crash site, about an hour and a half from the incident. They were mainly students in middle school. Most had significant burns injury. There was also this phenomena of misinformation on social media. The numbers were shockingly big and they were talking about 200 coming to the Burns Institute, and this was a scene at the A&E department or emergency department on the day of incident. So this disrupted movement of casualties into the institute and also disrupted the activity. So one of the key lessons learned was crowd control is very important. You need help from the security agencies to manage the burns. On the next slide, um, I was activated on the 22nd of July, and I reached the subsequent day at 10 p.m. The important part was that we had a lot of relationships and build up. So I was the only one coming in, performing the roles of needs analysis. For anyone helping any other country or chipping in, you need to know what is actually needed. So I was very fortunate to have close collaborations with the colleagues, starting from the day I was in the lounge in the airport, and facilitation through the immigration. The other part would like to bring up is that I roughly know what is needed. So one key aspect, if you are bringing extra equipment to any country, is to hand carry and then you yourself check in. This is better than using the logistic chain. Any surgeon, any doctor, or any clinical professional bringing tools will be very facilitated by airline staff. So I was allowed to bring in surgical blades, dressings, liquid fluids, as I have a full manifest prepared by my colleagues. The next thing was the very important triage and classification. No country, no center can manage 55 significant burns injuries. So the institute had actually gathered all the healthcare senior professionals throughout the country to have a big classification system to decide who and who cannot be treated and which are to go into palliative care. So this was done the very next morning, very early, about 6 a.m., when we went through all the 55 casualties. As you know, unfortunately, after 55, we decided that there were 11 or 12 of them that will be for conservative care. And the rest of it, once they are marked into the critical or severe areas, they're given priority to the intermediate and then distributed out to the various teams. The institute also, once the command and control setup is there, classification is there, then the resources can be distributed. And this allowed the institute to address the concerns of the public by having a press conference. So this was what was needed, a important classification, command and control setup that was set up, and then triaging the things. Besides Singapore, the Indian and the China both sent teams to come down to help. And we begin a cycle of twice daily road rounds and discussion on the resources. As the lead of all the countries, we work with the institutes to really discuss and prioritize treatment. And it's very important to know what is needed and what can be done in the institute. So, for example, we quickly realized that the Bangladesh had a lot of surgical assets, but they were lacking in ICU and infection control measures. So my team consisted mainly of intensivist ICU nurses and infection control nurses, and we quickly brought in the resources regarding like CVP tips, IA lines, special antibiotics, and this was also brought in by the various teams. It is also important to get in the seniors in the Ministry of Health so that they can bring in additional resources. For example, Director General Health in Bangladesh was able to provide additional funds to quickly procure the expensive antibiotics and also bring about resources. The other part is teams have to collaborate. So I'll be honest, Wuhan team from China had problems with language, but I speak Chinese very well. So I acted more like a scrub nurse and a circulating nurse for them. And I can then mobilize their 3 to 4 surgeons into action. So it's how international teams collaborate. While the Indian team were from Kolkata, so there was no problems with speaking Bengali. So they could somewhat work independently with the Bangladeshi team. And political office holder like the health advisor there are all trying to help. So you need to help package the information from the institute and translate to what is needed, and they will be able to provide better resources. For example, it was a clear need for more anesthesia help, more multidisciplinary care, and this was mobilized by the health advisor after having a chat. So we went on by the day 4, day 5, day 6, we were really, the key problems was combating infection, combating ARDS, and we were quite happy to introduce more monitoring, including that of IA line, and also proning the patients to combat severe ARDS. This was one of the earliest cases done, and this helped salvage probably another 4 to 5 patients in total. There was good hospitality from the host, taking care of all the international team, including chief advisor, who graciously hosted us on the night of the 6th day. You can see the China, India, and Singapore team were all hosted together right off from the hospital. We by day 6, it was quite clear that the infection control was a big issue. So we raised it together and formed an infection control task force, setting clear targets and exchanging ideas so that we actually can help manage the cross-contamination risk. Teaching was very important, and during lunch times or meal times is very important, and we try to translate additional information. It is also, we know help can last forever. It's important to ensure smooth handover, ensuring appreciation. Our stint in Bangladesh was very well hosted by the host. I think we do make a difference, and we also try to show some appreciation to the staff, especially the junior and nursing staff, who were really working very hard over the many days and helped us to take care of the patients. Some of the things that actually we did, the important part is really to key in and giving help and highlighting what is needed, and then highlighting it to the relevant people. The food is always important. We did enjoy the hospitality, but I think the key lessons learned, if we were to share, are this few. Number one, needs assessment is important. Walking the ground with the host is important. For example, clearly the need was within the ICU and infection control. Bring that resource. Logistic resupply can only be expedient and fast if you do it yourself. Bring it through. If you go through a logistic company, it will take time. Most importantly is integrate the whole system. All the countries and all the centers have intrinsic capability, and we must work together, one integrated force. For example, I was more like a circulating, more like a planning staff, because the other international teams brought certain skill sets. My job is to more integrate them all together. And this is the philosophy of think win-win all the time with all the international colleagues, so that you can tap on their resources. The other part, this was 11 days there. I had to exercise leadership because the teams were very enthusiastic to ensure work-rest cycle so that the team can last throughout the cycle. And it's important to teach, learn, and show appreciation whenever possible. And last but not least, I thought this is very important to have a clear plan to hand over. I'll be honest, there was a slight gap in the ICU capability, and we only left when there was 0 ICU patient to hand over, so that at least none of the patients are on ventilatory setting, so that we can hand over the place, slightly better place than before where we come from. So with that, I thank all the listeners on board, and it was a really great opportunity to contribute in a very tragic situation. Thank you.
Thank you, CJ, so much. That was so informative, and I have many questions. I'm sure that many of our listeners also have questions, but thank you very much for highlighting your response to that disaster so clearly, and the need for a needs assessment, triage, and the importance of teamwork, having the right resources, training, and having an exit strategy. I was also very interested in the role of social media and how that necessitated better crowd control from security agencies. So I'm interested to know maybe later about how that works out. And also the classification system, whether you used one that was already established or whether you determined one there and then. But for now, we'll move on to our next speaker, Dr. Tom Potakar, who was formerly Chief Surgeon at the International Committee of the Red Cross and Professor of Global Burn Injury at the Centre for Global Burn Injury Policy and
With
Research at
you can easily
Swansea
record,
University.
edit, and share high-fidelity short-form video messages, both internally and externally. Here's how to get started. Zoom clips can be...
Thank you. Tom has worked in the international field since 1990 with MSF in Cambodia, Bosnia, Tajikistan, and Rwanda. He was co-chair of the WHO Emergency Medical Team Technical Working Group on Burns, and he co-founded Interburns, and for which he's led programs including in Afghanistan, Nepal, India, Bangladesh, Pakistan, Uganda, and many other countries. So Tom will now talk to you on the importance of human factors, which CJ touched on just now. Thank you, Tom.
Good afternoon, everybody, and welcome to this webinar. You've been hearing earlier on about the preparations for how to cope with a mass burn casualty, and particularly around creating a plan, which is a vital step in the process. I'd like to now move on a little bit from that and talk about, okay, so now you have a plan, now what? So I'm imagining, as I'm sure many of you have, you're busy in your office or in the emergency department, and somewhere stored on a cupboard or a shelf, along with lots of other policies and guidelines, you will have a plan. Like here we have the plan for the management and standards and recommendations for burn care in mass casualty incidents. So this is a really important first step. And of course, that plan may be one that already exists, like these ones from the World Health Organization, or it may be based on these, or you may have created one yourselves with your team, etc. So this is a really critical first step, but of course, a plan sitting in a folder on a shelf somewhere does not get you where you're needed. So in any mass casualty situation, the critical part is, are the following people all aware not only of what they need to do, but are they actually able to do it? And as you can see, in a mass casualty scenario, it's not just the clinicians, but there's many other people involved in the management and in the excuse me, preparation and in dealing with such an incident. So once you have your plan, you then need to ensure that all these people that may contribute and be a part of it actually know what to do. So this may include clinical staff, as I say, but also non-clinical staff, administrative staff, management staff, coordinators, etc., etc. So they need to know what to do, but more importantly, they then need to actually do it. And another way of putting this is they need to have the knowledge, but then the knowledge on its own is not enough. That then has to be followed by action. So in order to undertake this process, we need to think about what's called dissemination and implementation. So dissemination is the process by which something is communicated in a way that can facilitate understanding and use. So with respect to the mass casualty plan, this means making sure that the right people understand what is in that mass casualty plan, and that they are aware of it, and they have read it, and they understand it, and how to use it. The implementation side is the processes by which many things, such as guidelines, recommendations, policies, etc., are incorporated into use. So one of these is around letting people have the information. The other is then around putting that knowledge, that information they have, into action. So it's a process that goes through informing and then takes what we know and turns it into what we do. Now, one way of looking at this is the knowledge to action pipeline. Now, this is a really important step that allows us to understand where there can be blockages and problems to the implementation process. So in this, the first step is, are people aware? So in the case of a Burns mass casualty plan, are they aware that it actually exists? Have they seen it? Do they know where to find it? Secondly, do they accept it? So they may be aware it exists, but they may not accept what's written in it. Is it applicable to them? So some people may read it, but actually they're not going to be any part of it, whereas others, it will be something that is extremely applicable to them and relevant to them. Are they able to actually act on it? So this is around, are the resources there? They may be aware of it, they may accept it, it may be relevant and applicable to them, but they're not able to do it because they don't have the appropriate resources. With all that, do they then actually act on it? So this is the part, do they actually then follow what is in this plan when a mass casualty event happens? Once it has happened, and then there's a review process, etc., do they agree that what went on was appropriate, was good? Are there lessons to learn? Do they agree that it's a good framework for the performance in a mass casualty event? And then the final step is around sustainability, and will they adhere to this in the future? So this knowledge to action pipeline can be used in many, many different scenarios. And one that I think is very pertinent, for example, is hand washing. So we know that hand washing causes, or rather prevents, a huge amount of complications globally in healthcare, and yet it is still not taken up 100%. And many places, as I'm sure you've all seen and are aware of, people do not use hand washing as it should be before and after clinical interventions, where it should be 100% implemented, but we know that it isn't. So if we look at this process here, most people are aware that hand washing is important, and most people do actually accept it. And if not, this is around a knowledge part of the pipeline. It's far more applicable, obviously, to doctors and nurses than it is perhaps to secretaries or managers who have less interaction. So it's important that those that it's applicable to are aware of it. Now, then we start to get to the more difficult parts. Are people able to do it? Well, sometimes there's problems with lack of water, lack of soap, lack of alcohol gel, etc., which means they may be aware, they may accept it, it may be applicable to them, but they're not able to do it. Or maybe they are able to do it, but they just don't do it. And now we're moving into more the disciplinary side of things. So as you see at the far left of this, it's more around knowledge. In the middle, it's more around quality improvement. And to the far right, it's more around actually just disciplinary matters. So let's quickly mention what we mean by a dissemination strategy. So this can be either general or targeted, or a combination. So do you tell everybody everything, or do you focus on specific groups and give each group what they need to know, but nothing more, or a combination of both? You need to engage all the stakeholders, establish processes and materials, delegate specific tasks, and set a deadline. And if we look particularly at establishing processes and materials, this will be around different ways that can be done. It can be through compulsory training. It could be through disseminating a monthly meeting every month over a period of 6 months, or done 3 times a year and repeated every year 3 times. It could be through posters in various places, action cards, a mobile phone app, email. It could be linked to performance review or even linked to a social event. So there's a lot of different ways that we can look at for actually disseminating the knowledge and the information. What then about the implementation strategy? Again, one good framework for looking at this is called the Framework for Implementation Research. And this talks about the innovation. So that is the thing that needs to be implemented. So in this case, we're talking about the mass casualty plan. Then there's the inner setting, and this is the setting in which the innovation is implemented. So in this case, we're talking about hospital, pre-hospital, emergency room, operating theatre, wards, etc. The outer setting is the wider environment, so the health system, transport, communications, finance, etc. And then the individuals, this is around the roles and the characteristics of the individuals involved in this plan. So those that are actually going to be acting on this plan. And then the process is the activities that are used to implement the innovation. So it's a useful framework to look at these 5 different areas. And then when we think about what we want to achieve, it's really that the final step in the pathway is around behavior. It's around people having the knowledge and then acting on that. So that acting on that is their behavior. And there's a useful model for this called the BCOM, which talks about behavior being related to the capability or the capacity, the opportunity and the motivation. So for the capability, somebody has to have the knowledge, the training and the experience. So for example, if they've been asked to triage patients that are arriving in the casualty department, do they have the knowledge to do that? Have they been trained in it? And do they have some experience? And with those 3, they will have the capability to perform that task. The opportunity is around the resources and the personnel. So should a mass casualty event occur and they've been asked, for example, to triage, or do they have the resources available? Are there enough personnel to do that job, considering the number of patients? How many staff do they have? And with those staff, do they have the appropriate resources? Do they have scissors to cut off clothing? Do they have stethoscopes to listen to the lungs? Do they have dressings to dress the patient after they've seen them, etc.? So do they have the opportunity? The opportunity is around the resources and the personnel, and can also be considered as the sort of physical requirements and the social requirements. Are they actually allowed to do what they've been tasked to do? And finally, the motivation. And motivation can either be intrinsic or extrinsic. And this is often the most difficult one, because people may have the capability and the opportunity, but when it comes to the actual action, it's around the motivation. So this is a particularly interesting area that has a significant impact on implementing any intervention. So again, engage stakeholders, use the knowledge to action pipeline to identify where the problems are. Is it because people are not aware? Is it because they don't agree? Is it because they don't feel it's relevant or they're not able to, etc.? And then target specific individuals or groups based on that analysis. Identify barriers and facilitators with processes, the inner and the outer setting. So not just those things that are immediately obvious, but also from the wider environment. What are potential barriers and facilitators to implementing this mass casualty plan? And then use a PDSA, a plan, do, study, act approach to try and engender continual improvement. So in the end, it's not about what you know, it's about what you know and, more importantly, what you actually do. Now, the real world scenario, of course, is very different. So if we look here, this is a typical scenario in a mass casualty when there's lots and lots of ambulance arriving, they're all backed up. It's difficult to get into the casualty. Patients may have been arriving in a completely different order from you were hoping they might arrive, and this can make life very difficult. It's also, in a real world scenario, things never quite go according to plan. There can often be disruption. So here again is a typical mass casualty event. And you can see here, this is by no means abnormal. You have lots of people. you have relatives, you have family, you have other staff, other people. And it's really important to accept that this is the real world. We have to understand that whilst those working in the hospital may have gone through training and understand the process for dealing with a mass casualty, those that are arriving and their families and relatives, they have not. So it's important to understand that and to not expect miracles, but just to do the best you can. And having a framework can at least provide a good springboard for doing that. But we have to accept that this is a real world scenario where the behavior of everybody else, it's difficult for us to influence that. And therefore, things often don't go quite as we would hope they would go. So in summary, do you have a plan? Yes or no? If you don't develop a plan, then if you have that, are people aware of it? If they're not, you need to work on a dissemination strategy. If they are aware of it, do they actually know what to do? If they don't, then you need to develop the implementation strategy part. And then once that is done, you need to perform regular exercises and simulations to ensure that people don't forget, that they keep up to date, and to regularly check that each person knows what they need to do in the specific environment of a burn mass casualty scenario. So I hope that's just given a little indication as to how you need to think beyond the plan itself, but to the actual implementation of that. Hopefully you won't have to face a burn mass casualty, but if you do, I hope some of the talks today will help you cope with it. Thank you very much.
Thank you, Tom. Thank you for a very beautiful and nice presentation. Actually, you tried to highlight on the WHO recommendation. That is the actually our recommendation officially. But there should have a different plan for the developing world. How to develop the plan for a mass casualty disasters, and highlighting on the reality versus the real world scenario, and the world standard versus the resource limited uh, scenario. So you try to highlight and to compare between these things. So the summary is simple things are required for all. Now we are going to enter into the question and answer session. So Lucy.
Thank you so much. To anybody listening, if you have questions, then please put it in the Q&A session, and we can ask Dr. Tanvir and CJ for their answer. I have some questions to start off with, if I can. So we've heard from Dr. Jayesh about the Ahmedabad plane crash and the bomb blast in 2017, and then from Nikki about the need for systematic triage. And about the Bangladesh chemical warehouse explosion. And running through each of those disasters is the word triage. So the need for rapid triage and the understanding that the hospital can't take in all this flood of patients at one time. So I think my question to both of you is, CJ mentioned you developed a classification system. So I'm just wondering, was that a completely bespoke system that you developed for that specific scenario? Or was that one that had been pre-developed and you amended it? I'm just wondering how easy it was to develop that triage system for that particular event, and if you had to adapt others, or whether you just looked at your own circumstances and built it from scratch.
Thank you, Lucy, for the question. So it is somewhat modified from the sort of ABA standards. We arbitrarily drew a line at 40% to call it critical, and anyone above 60, we more or less based on the known box scores and survivability, we decided arbitrarily at that time those to be at the unsurvivable. This was a very painful call, but we got all the experts in to have some sort of consensus. So it was like a 20, 40, and then above 60, we classify into the various categories, and with or without the inhalational injuries, we added points for that. So it was reasonably systematic. Everyone had to agree to it before we moved them in. So in short, it was more modified, but building consensus with the teams on the ground, especially the host, is most important, because they will know what is more survivable in terms of that mass casualty? Over.
Thank you very much. Tanvir, do you have anything you'd like to add to that? Or...
Yeah, actually, what CJ was telling about and what highlighted in the Tom Tucker's presentation or even from Jayas, the scenario in our developing world is totally different from other part of the world because this setting we are dealing with large number of patients with a limited resources, not only the resources, but also the manpower, the doctors, and the facilities. Number two challenge with the crowd control. Whenever there is an incident, lots of people, along with the patient, their attendants, and the curious people from the streets actually enter into the hospital to see what's going on. Even the media, that is another challenge. And lots of cameras and the camera personals and the reporters enter into the hospital to actually uh, to show the breaking news. So it actually creates a lots of problem inside the hospital. So sometimes it's very difficult to maintain that triage or to safeguard the patients in the emergency room because all are entering, breaking all the barriers of the safety, security, even the sterility of the hospital. So these are lots of challenges. But during managing the patient, actually what we have learned from CJ, they actually plan for a quick uh, development of the triage plans to categorize the patients and then focus how to focus in that situation. So that was really good. Yeah.
Thank you so much. There's a question in the chat box. Do you have any insights on what is known about the actions of spontaneous responders? So the citizens who find themselves in the middle of a burn mass casualty incident before the emergency services arrive there. What is known about the value of their early interventions, and what could the burn community do to ensure that society and community resilience to burn incidents? Do you have any thoughts on that?
For CJ?
For CJ, any of you?
I guess in various countries there will be various responses. So Singapore is very developed with lots of simple access to public education. So I guess on that part, we even have apps to develop to tell people what to do. For example, bring them to safety, find a water source to rinse them down and all that. So there's this what we call Singapore Secure app where the information is there to prompt you. In fact, they will get BCRS responder to respond nearby. So this is really we're in a very fortunate situation, and ambulances will arrive. So I guess that is really good. But I guess if it is also a mass casualty where local capabilities are overwhelmed, then the bystanders' actions will be important. Taking off the burn clothing, rinsing, and all that will need to be secure. And this is when all these apps in this situation, particularly for the younger generation, can play a part because they are not professionals. They don't remember in the short term, but the apps and all that can actually remind them rapidly in a short time. So that's something we can consider as the world move forward in this new age. Over.
And obviously, I think for Tanvir and Dr. Jayesh, it's very different in your settings. Social media, everyone has their phones. It's potentially more chaotic than Singapore. Is there anything that you think can be done to improve awareness of how people should react in a mass casualty burn disaster? Or
Hello?
Dr. Jayesh, hello.
Yeah, like sir told, there should be awareness in the society. If such type of incidents occurs, then what people have to do, where they are supposed to take these patients, how to safeguard themselves. So at various intervals, such awareness program should be conducted by the burns community. So if such type of unfortunate incidents happen, so they can actively participate and they are aware about what to do, what not to do, where to shift the patient, where to bring the patient, whom to contact, etc., etc.
Thank you. And Dr. Tanvir, I know that CJ mentioned that it was very important to have an exit strategy with longer term benefit and follow up after the Bangladesh disaster. Do you know if that has led to any more planning for such future events? Is there more of a system in place in Bangladesh now if there are those events, or is it already quite well structured as to what happens?
Yeah, thank you. Actually, we faced lots of disasters, starting from a small one, middle size, or a large burn incidences very frequently. Even after that incident, that plane crash, already in between these 3 to 4 months, we already actually experienced another 7 to 8 disasters. So actually, in reality, uh, we should develop our awareness program. Needs to prevent. Without prevention, it's very difficult because this is a country with 80 crore people, a small limited place. So without awareness, with our limited resources, it's quite impossible to tackle with the number of the patients, because we can develop, we can raise our standard of care, but when a big number of patients are coming, we can actually provide a good uh, service to the patient to salvage them. So we are trying to develop some awareness programs, trying to motivate the government based on the overseas team's experience. We are sending the proposals to the decision makers, the government and the politicians. And these are the problems, and which one is the cost effective? Cost effective one is to prevent. Need awareness, fast response. In our setting, there is another problem. If you consider the ATLS, so it needs the first hour response. But in our reality, in the field, there is no resuscitation or a good rescue team or the first responders. Patient used to come directly to the hospital and any other means without any resuscitation. That actually killing the main bulk of the patient. Whenever they reach in our hospital, we have all the facilities that we can reach, actually save the patient. And what was actually asking about question by Christy. I know Christy is working very well on the burn prevention. So actually, it is really that uh, in our scenario, we are getting information not through the proper channel. We are getting the information of any mass casualty in our country from our media. That is the reality, or from the Facebook, or from the social media. And in the first instance, we actually get that news and we share that news in our WhatsApp uh, group of our hospital. Then we start to rush. So that is a good thing. But bad thing is that lots of controversies and misinformations, misleading news are there. For example, one patient died, they are reporting that 20 patients died. There is 30 casualties, they are mentioning 300 casualties. So sometimes that are creating problems and they are trying to enter into the hospital. So we can protect them. So that is actually breaking the barriers of the infections, controls, and everything.
Thank you so much. And I hope that World Burns Week and throwing a light on the importance of prevention and focusing this day on preventing the chaos of mass casualty burn disasters will help to raise the profile and the need to plan. And it needs to be an integrated approach, really, so that everybody is working together. But I'd like to thank you all so much for your presentations today. And we will draw this session to a close with a few final slides. As you know, this is day 4 of World Burns Week. If you'd like to have a certificate of attendance, please scan this QR code and fill out the feedback survey, and then you can get a certificate. Thank you so much for attending. This has been a full week of webinars, and tomorrow, day 5, presenting isolation through community and connection. And you'll be able to access recordings of all these webinars through our www.worldburnsweek.org website. And we urge you to think of local activities that you can still carry out or plan them for next year. And we have a very good map on our website where you can actually post what local activities that you have done to raise awareness of burns in all its aspects. So thank you so much. And I'd like to really thank our speakers very much indeed for such great presentations. Save the date for next year, 2nd to the 8th of November 2026. Thank you all again, and yeah, hope to see you next year. Thank you. Goodbye.
Thank you.
Thank you, Lucy.
Thank you.
Thank you. Thank you, everyone.